Hello, dear colleagues, and welcome to Longevity Code, the blueprint for the doctors of the future. I am so happy to see all of you here, and please text us where are you from, so for us to see our big community, and I'm so happy to see the doctors from all over the world. My name is Dr. Ekaterina Lica. I am a dermatologist with more than 20 years of clinical experience and practicing in UAE and Europe, specializing in functional dermatology and regenerative medicine. I am a diplomat of American Board of Regenerative Medicine and the founder of Lica.Doctor Academy, as well as co-author of the educational program Longevity Code that we created together with our scientific director, Dr. Alla Zaentc. Dr. Alla is UAE functional medicine physician with more than 15 years of experience in hormonal health, peptide therapy, metabolic optimization, and also weight management. She is certified by American Board of Regenerative Medicine, also Functional Medicine University, USA, and also Canadian Board of Weight Loss Management. And together we focus on translating complex science into structured clinical protocols and also practical algorithms that physicians can confidently implement in real practice. And today's webinar is titled Peptides Between Evidence and Illusion. So peptides are now widely discussed today. They are trending in functional medicine, aesthetics, metabolic medicine, hormonal optimization, in regenerative practice, in sport medicine. But as physicians, our responsibility is clear. We need to understand where is the evidence, where are the real clinical indications, where are the structured dosing strategies, and where are the or we just following enthusiasm without sufficient depth. And this session is designed especially to clarify those distinctions and to do it calmly, clinically, and objectively. And later, during our webinar, I will explain you more about our longevity code and also about peptides module. And now I'm pleased to pass the floor to our scientific director, Dr. Alla Zaentc. Dear Dr. Alla, now is your turn.
Good afternoon, dear colleagues. I'm very happy to see all of you here today, and it's basically my pleasure to see all of you in this evening, and thank you for being us here. So the topic of peptides has become almost impossible to ignore, and they are discussed at major medical congresses, actively used in anti-aging and metabolic clinics, widely promoted on social media, and sometimes, unfortunately, oversold as near miracle solutions. And yes, many of us in this room use peptides not only in clinical practice, but also personally. And this reflects how deeply peptides have entered modern medicine and physician culture. And at the same time, this popularity creates responsibilities. So my goal today is not to promote peptides, but to help clearly define where real biochemistry ends and marketing begins, and how we as a physician can responsibly navigate this rapidly growing field. So some clinicians see peptides as the future of precision and regulatory medicine. Others consider them hype, poorly regulated compounds with exaggerated claims and limited evidence. And in reality, both perspectives contain truth. And today, we start from the fundamentals, what peptides actually are and why they play such a critical role in human physiology. We will then explore why peptides have become so popular at this specific moment in time, and what illusions and misconceptions surround them, and how to evaluate peptides using a clinical and scientific framework rather than just trends. And finally, we will briefly but meaningfully discuss several peptides that are currently shaping this field. I'm talking about most retatrutide, CGC, apomorelin, and BPC, focusing not on promises, but on mechanism of action, available evidence, and realistic clinical expectation. And after the introduction, a very natural question arises: why exactly now? So peptides have existed for decades. All of us know insulin. It was the first peptides came into this scene, and many of them were discovered long ago, and some are well known in classical physiology. So why have they suddenly moved from textbooks into daily clinical conversation? First, we are facing a rapidly aging population. So patients are living longer, but not necessarily healthy. And we are no longer treating isolated diseases. We are managing complex overlapping dysfunction. We have patients with insulin resistance, sarcopenia, chronic inflammation, mitochondrial decline, neuroendocrine imbalance. And classical pharmacology was not designed for this level of complexity. It's mostly about symptomatic treatment rather than addressing the root cause of the problem. Second, we are in the middle of a global epidemic of a metabolic disease. Obesity, type 2 diabetes, fatty liver, and cardiometabolic risk are no longer condition of old age. They affect patients in their 30s and 40s, and these are not single pathway problems. They involve energy metabolism, hormonal signaling, inflammation, and cellular stress response. So peptides fit naturally into this multidimensional space. Third, we are reaching the limits of traditional pharmacology. Many standard drugs work by blocking or forcing pathway, inhibiting enzymes, suppressing receptors, overriding physiology, and this approach is effective in emergency medicine, but often comes with side effects, compensatory mechanism, and long-term trade-off. So peptides, in contrast, tend to modulate rather than dominate biological systems. And of course, finally, there is a growing demand for precision and personalization. So patients no longer want one-size-fits-all solution. They want therapies that align with their biology, their metabolic status, their age, their goals, their lifestyle. So peptides speak the language of the body, short signaling molecules that can interact with specific receptors and pathways in a more physiological way. So peptides didn't become popular by accident. They appeared at that exactly moment when medicine began to shift from symptom suppression toward system biology and regulatory medicine. And the problem is that this same moment also created space for oversimplification and illusion. And that's where our critical thinking as a physicians become essential. And before we go deeper, I want to clearly set expectation for this lecture. So this lecture is not designed to turn peptides into another trend or magic solutions. It is also not meant to replace your clinical judgment or experience. Peptides are not protocols you can copy and paste. They are tools that require understanding, context, and responsibility. And what this lecture will do is explain the physiological role of peptides, why they are fundamentally different from many classical drugs, and how to evaluate them through the lens of evidence rather than just enthusiasm. And I will share a framework that you can apply not only to the peptides that we discussed today, but to any peptides you encounter in practice or marketing materials. So what this lecture will not do is promote miracle claims, universal dosing strategies, or simplified algorithm like these peptides work for everyone. No, biology doesn't work that way, and peptides, perhaps more than any other therapeutic class, remind us of that. Another important point, we will talk about peptides as a part of systems medicine, not as isolated interventions. And their effects depend on sleep, nutrition, metabolic status, inflammation, and hormonal balance. So when peptides fail, it is often not because the molecule is ineffective, but because the biological environment is not ready to respond. And again, by setting these boundaries early, we create space for an honest and clinically useful conversation. With that foundation, we can now move into the fundamentals, what peptides actually are beyond their marketing language. So let's step back and define what peptides actually are beyond the buzzwords. So at the most basic level, peptides are not foreign substances in the body. Many of them are endogenously produced and act as a regulator. So they messages that allows cells, tissue, and organs to communicate with each other, and they're involved in almost every essential physiological process. I'm talking here about metabolism, growth, immune response, neuroendocrine signaling, repair, and even adaptation to stress. And also peptides are very short chain of amino acids usually consisting of 2 to about 50 amino acids. And this may sound simple, but functionally, peptides represent one of the most sophisticated communication systems in the human biology. So what makes peptides unique is their specificity. So most peptides are thought well-defined receptors triggering highly targeting and signaling cascade. Unlike many classical drugs, which often influence multiple pathways simultaneously, peptides tend to deliver very precise biological instruction. Another important feature is their short duration of action. Peptides are designed by nature to act quickly and then be degraded. And we often see and listen from our patients when they use, for example, CGCI pomorelin, and then when they will finish the course and they will go to do the blood test that, okay, my IGF-1, my growth hormone is again in the lower borderline or even not exist in the body. So why is the peptides not active or not working in my body? Actually, no. This is only because our peptides have very short duration of action. They make their work and they disappeared. So we don't have any storage for any kind of peptides in our body. And so when we talk about peptide therapy, we are not introducing something artificially into the body. We are attempting to interact with existing regulatory system and sometimes enhancing them, sometimes restoring them, and sometimes mimicking signals that decline with age or disease. Again, understanding this concept is critical because peptides don't force the body to change. They ask the body to respond. And whether the body can respond depends entirely on the biological context, something we will come back to repeatedly throughout this lecture. And again, one of the most common sources of confusion, even among clinicians, is the distinction between peptides, proteins, and hormones. They are often discussed interchangeably, but functionally they behave very different. So let's start with size and structure. Proteins are large, complex molecules with long amino acid chains and three-dimensional foldings. Peptides are much smaller, and this smaller size allows them to move more easily between compartments, interact rapidly with the receptors, and be degraded efficiently once the job is done. Hormones on other side are defined not by size, but by function. And some hormones are peptides. For example, insulin is a classic example. And others are steroids or amines. And what matters clinically is that peptide hormones tend to act through cell surface receptors, triggering intracellular signaling cascades rather than directly entering the nucleus. And this leads to the next difference, speed of action. So peptides usually act quickly. They bind to receptors, transmit signals, and are then broken down. And this makes their effects more dynamic and adaptable compared to steroid hormones, which often have slower but longer lasting genomic effects. And perhaps the most important distinction in how peptides influence physiology. Many classical drugs and hormones work by forcing a response, suppressing a pathway, or relapsing a missing signal. Peptides, in contrast, are primarily regulatory. They modulate existing system, amplify or fine-tune signals, and depends heavily on the responsiveness of the target tissue. And this is why peptides often produce subtle but meaningful changes rather than just dramatic immediate effects. And this is also what we noticed in our patient, for example, who use again the CGC ipomorelin. They suspect to get fast results compared with the anabolic steroids. But unfortunately, peptides not like anabolic steroids. They work more gently, but in the same time, more safe. And to truly understand why peptides matter, we need to look at their role in maintaining homeostasis, the body's ability to adapt, regulate, and survive in a constantly changing environment. So peptides are one of the most primarily language cells used to communicate with each other. And they transmit information about nutrients availability, stress, damage, energy status, and repair needs. And without peptide signaling, coordinated physiological responses simply wouldn't exist. In the neuroendocrine system, peptides regulate appetite, they regulate our sleep, stress response, growth hormone release, and of course, our circadian rhythm. And many of the symptoms we see in modern patients is a fatigue, sleep disturbance, weight gain, reduced recovery, reflect dysregulation at this peptide signaling level rather than just a signal organ failure. In the immune system, peptides act as a fine modulators. They don't just turn immunity on and off, they shape immune balance, tolerance, and resolution of inflammation. And this is particularly relevant in chronic low-grade inflammation, which underlies aging, metabolic disease, and many degenerative conditions. And metabolically, peptides play a central role in energy sensing and mitochondrial function. So they help cells respond to nutrient excess or deficiency, physical stress, and oxidative load. From insulin signaling to mitochondrial-derived peptides like MOTSI, peptide regulation is deeply embedded in how cells decide whether to store energy, burn it, or repair themselves. And what's important to understand is that peptide signaling tend to decline or distort with age and chronic disorders. And receptors become less sensitive, signaling become noisy, and adaptive response weakens. So peptides-based therapies attempt to intervene at this regulatory level, not by overriding physiology, but by restoring clarity to the signaling system. And this brings us to a critical insight. Peptides are powerful, but because they are new, but because they are fundamental. And this is exactly why they can be both effective and easily misunderstood. And from a clinical perspective, peptides are attractive, but because they are fashionable, they offer several real and meaningful advantages over many traditional therapeutic approaches. And one of the most important advantages is high receptor sensitivity. Most peptides are designed by naturally or by pharmacology to interact with a very specific receptors. And this allows for targeted signaling with a less intended interference in unrelated pathways. In theory, this means fewer side effects and more predictable biological response. Another key point is that peptides tend to follow physiological signaling patterns. So instead of forcing a pathway on or off, they often amplify, restore, and gently modulate existing signals. And this is particularly relevant in conditions where regulation is impaired rather than completely absent, such as an aging, early metabolic dysfunction, or chronic stress-related disorders. And peptides generally carry a lower off-target burden because they are quickly metabolized and don't accumulate in tissue. Their long-term systemic toxicity is often lower compared to small molecule drugs. And this doesn't mean they are risk-free, but it does mean their risk profile is different and often more manageable when used correctly. And of course, finally, peptides work at a system level. So they don't just target organs, they influence communication between different systems, endocrine, metabolic, immune, neuronal. And this makes them especially relevant in complex patients where symptoms cannot be explained by a signal, isolated pathology. However, all these same advantages can easily be misinterpreted. High specificity doesn't mean guarantee effectiveness, and physiological signaling doesn't mean universal safety, and system level effect don't mean one peptide can fix everything. So now let's look more closely why peptides are so appealing in clinical practice. First, of course, anti-aging medicine. As we know, aging is fundamentally a loss of regulatory capacity at multiple levels: hormonal, metabolic, mitochondrial, and of course, immune. And peptides act as a regulator, often restoring or amplifying signals that naturally decline with age. And this is why they are widely used in longevity clinics and by physicians focusing on preventive medicine. Second, it's a metabolic health. Peptides can influence glucose metabolism, insulin sensitivity, apoptite regulator, and fat storage. I'm mostly talking here about our incretins, semaglutide, tirzepatide. And for patients struggling with early metabolic dysfunction or weight gain, peptides can complement lifestyle interventions and, in some cases, pharmacologic therapy, especially when traditional approaches are insufficient. Third is a body composition optimization. Certain peptides modulate muscle growth, fat oxidation, energy expended, For example, combining signaling through growth hormone or mitochondria peptides may support lean mass preservation, fat reduction, or both, again, in a context-dependent manner. And finally, recovery and performance. So peptides are increasingly used in sport medicine and clinical recovery settings because of their potential to support tissue repair, enhance recovery from injury, and improve overall resilience. Importantly, these effects are subtle and physiological rather than creating artificial or pharmacological superhuman performance. However, it is critical to remember the clinical appeal can sometimes overshadow the evidence. Patient, colleagues, marketing materials often emphasize results without context. And again, our role as a physician is to understand the mechanism, evaluate the data critically, and set realistic expectations for each individual patient. And now that we discussed why peptides are appealing, let's break down the main functional categories that clinicians encounter in practice. Again, understanding this classification is essential for both choosing the right peptides and setting realistic expectations. First, we have hormonal peptides. These regulate for metabolic and physiological process. And classical examples include insulin, somatostatin, and in clinical practice analogs like CGCI pomorelin, tesamorelin, sermorelin, or even IGF-1, kisspeptin, PT141. All of them used to modulate growth hormone signaling in controlled pulsatile way. Second, neuropeptides. These are involved in nerve signaling and cognitive modulation. CLUNK, CMAX, dihexa, for instance, can influence anxiety, memory, neuroprotection, neuroplasticity, and cognitive improvement. Third is antimicrobial peptides. These are part of innate immunity and show antibacterial and antiviral activity. Defensins and catalycins are naturally occurring examples. Fourth is immunomodulatory peptides. Thymosin alpha is a key example used to modulate immune responses, improve immune balance, and sometimes support recovery after viral infection. And it was one of the first peptides that was actually FDA approved to treat some viral diseases like HIV, hepatitis C, and it was a part of the traditional protocol. Fifth is regenerative peptides. These accelerate tissue repair, wound healing. BPC-157, thymosin beta are a prominent example used in musculoskeletal soft tissue repair context. Sixth, we have antioxidant peptides, molecule like a glutathione, protect cells from oxidative stress, which is central to aging and chronic disease. Seventh, we have a mitochondria peptides. We have here MOSI, we have CSS31, elamipretide. Similar peptides enhance mitochondria function, energy metabolism, and stress adaptation. And this is an exciting area in longevity and metabolic research. And basically, SS31 was another FDA-approved peptides to treat mitochondrial dysfunction. And finally, anti-aging peptides. We have here gainapitolone that able to increase the length of telomeres and dihexa that improve neuroplasticity. They represent interventions aimed at slowing biological age process, supporting systemic rejuvenation rather than just targeting one organ or pathways. Again, this takeaway here is that peptides are not a single entity. They are diverse toolbox, each with specific mechanism, targets, and potential indication. Also, what you have to remember that peptides like a coin, they have both sides with the benefits, with the side effects, and we have to accept both of them. However, with this diversity comes complexity. Not every peptide will work for every patient, and evidence level vary widely across different categories. And now that we review the variety and appeal of peptides, it is essential to address the illusion problem, the gap between hype and reality. First, many peptides are promoted based on weak or preliminary evidence, often from small-scale studies or animal models. And while this data can be promising, extrapolating it directly to clinical practice is quite risky. A peptide that improves metabolic markers in mice doesn't automatically translate to safe and effective outcomes in humans. So we always prefer to use a peptide from the local compound pharmacy that accredited by the local government instance, so licensed and under the control. Second, there is a tendency to present in vitro or animal data as a proof of human efficacy. You will often see claims like these peptides boost longevity or reverses metabolic syndrome based on cell culture experiments or rodent studies. As clinicians, we must recognize the difference between mechanism of action inside and clinically validated results. That's why we will never use the peptides for research. We will use licensed peptides. And finally, there are practical dosing, purity, and sourcing issues. Many peptides used in clinics or purchased online vary in concentration, stability, quality. I saw a lot of time when even my patient got from online stock powder for the peptides so that they have to reconstitute at home, and the vial is absolutely white. There is no protection from the light. So what it's very questionable about the quality of this product at the end of the story. Again, the illusion problem exists because peptides are inherently attractive. They are biological, subtle, promising, system-level modulation, but popularity combined with incomplete evidence creates fertile ground for over-promising. And as a physicians, our responsibility is to evaluate the evidence critically, understand the mechanism, and recognize limitation before integrating peptides into clinical care. And this will guide us safely into the next section, where we discuss how to assess peptides evidence and clinical potential. So let's decide how to select and handle peptides safely, because the quality of the peptides directly affects both efficacy and safety. So peptides are inherently unstable molecules. You cannot just shake them. You cannot keep them in the room temperature. You cannot them keep under the light. They can degrade quickly if exposed to heat, light, mechanical agitation. You cannot mix peptide. This is also important in one vial. And even shaking a vial too vigorously can break the peptide bonds and reduce biological activity. For this reason, peptides must be handled with care during reconstitution and storage. And one reconstituted with a sterile water or backwater, most peptides are best used within 24 hours. And this is another fail that we meet when we order peptides online, because in one vial you will have multiple dosage. And after reconstitution, without using additional substances to stabilize this solution, you unfortunately cannot keep it even in the fridge. And beyond that, the activity may decline, and there is also a risk of microbial contamination if storage conditions are suboptimal. And when choosing a supplier, always source from licensed pharmacy or an approved pharmaceutical supplier. Avoid products labeled for research use only. We see a lot of cases when patients get peptides from online stock reconstituted, and then there is some precipitants on the bottom of the vial and some substances swimming inside. This is not how it's supposed to be, as they are not manufactured to clinical grade standards, may lack sterility, may not have proper purity testing. So other critical considerations include packaging. Peptides should come in dark or opaque vials to protect from light-induced degradation. Cold chain supposed to be support. They must be shipped and stored at the correct refrigerated temperature using 2 to 8 degrees, and any deviation can compromise stability. Documentation. Always request a certificate of analysis confirming purity, identity, and absence of contaminations. Expiration date. Check the shelf life and ensure peptides are used before expire, even if stored correctly. So in practice, these steps are essential. Even the most promising peptides can fail to work, or worse, become unsafe if it's improperly sourced, mishandled, or stored incorrectly. And as clinicians, ensuring quality and stability is not optional. It's a core part of patient safety. So once we know that peptides are and how to choose them, the next practical question is how to administer them. Most peptides are delivered injectably, either from vials that require reconstitution or through prefilled pens. And injection, whether subcutaneous or intramuscular, we have peptides that can be introduced intramuscular, like for example cerebrolizin, ensures the peptide reaches the bloodstream tissue bypassing the digestive system. And for many peptides, this is the only way to achieve reliable biological activity. And some peptides are marketed in oral or sublingual or nasal forms. And while these routes are convenient, the reality is that the digestive system breaks down most of the peptides. So not all peptides can be taken orally. Most important peptides, I think, that are available in oral form is KPV, BPC, and dihexa. Most of other peptides, unfortunately, will be break down. And stomach acid and digestive enzyme can rapidly destroy them, making oral administration ineffective for many molecules. So if you see epitalon in capsules, avoid this medication. If you see GHK Cooper in oral cups, you have to ask the question why you will use this GHK Cooper. Is it for gut healing or for skin glowing? If it's for skin glowing, this is not your form. And only specific peptides with a particular chemical modification or protective formulation can survive digestion and remain active systemically. Topical formulation exists as well and usually applied to the skin or mucous membranes. Absorption is variable and depends on molecular size, lipid solubility, and formulation. So clinical effects are often inconsistent, but still we have some peptides that are available in the serum form. And the key point for clinicians is this: not all peptides work orally, and assuming so can lead to both wasted therapy and disappointed patient. Injection remains the most reliable route for most clinically relevant peptides. When oral or other alternative routes are used, always check the literature for evidence of bioavailability and efficacy. And again, before we move into specific peptides, it is essential to address common misconception that we have now and that often mislead both clinicians and patient. So the first myth is natural equals safe. Just because a peptide exists naturally in the body doesn't automatically make it harmless when administered exogenously. So dosing, purity, patient context all matter. Even a naturally occurring peptides can cause unwanted effects if given in the wrong dose at the wrong time or in the wrong formulation. I can give you simple examples. CGC apomorphine can be very potent to build the muscle mass, but it can also trigger insulin resistance. BPC 157 can help you to heal the gut, but it also can stimulate the angiogenesis. So we have to be very careful if the patient has an active cancer. The second misconception is peptides equals stem cell activation. So marketing often exaggerated regenerative claims. While some peptides may modulate stem cell activity in some experimental settings, these effects are subtle, content-dependent, and not equivalent to tissue regeneration or miracle healing. So the myth of one peptide fix everything. Expecting a single peptide to simultaneously improve metabolism, body composition, recovery, immunity, cognition is unrealistic. Most peptides act through specific receptors and pathways, so their effects are targeted and not universal. And two additional myths are very common and clinically important: no side effects. In reality, peptides can have side effects ranging from mild injection site reaction to hormonal imbalance or metabolic changes, and the risk may be lower than for some drugs, but it's not zero. The second myth is not contraindication. So peptides are not automatically safe in every patient. Condition like uncontrolled diabetes, cancer, pregnancy, severe organ dysfunction, mitochondrial dysfunction, or interaction with other therapies can make certain peptides unsafe. And recognizing this misconception is a key for clinicians. It allows us to set realistic expectation, minimize risk, and communicate responsibly with the patient, separating hype from evidence-based practice. So, how to evaluate any peptides in a clinical context? This systematic approach separates hype from actionable science. First, mechanism of action. Always ask, how does this peptide work at the molecular level? Understanding this mechanism helps predict effects, potential off-target interaction, and plausible outcomes in patient. Second, target tissue and receptor specificity. So not all peptides act systemically. Many are highly tissue specific and interact with particular receptors. And knowing the target allows us to anticipate which physiological system will respond and where potential side effects may arise. Third is pharmacokinetics. So consider absorption, distribution, metabolism, and half-life. So peptides often degrade quickly, which impacts dosing frequency and administration route. For instance, a peptide that is rapidly metabolized may require subcutaneous injection rather than oral administration to achieve clinical effects. And finally, look at clinically relevant endpoints. So beyond mechanism of pharmacology, ask what outcomes matter for patient: weight loss, metabolic improvement, tissue repair, or cognitive enhancement. So evidence should demonstrate measurable and meaningful changes, not just lab markers or theoretical effects. And by systematically evaluating peptides along with these 4 dimensions, mechanism, receptor specificity, pharmacokinetics, and clinical endpoints, clinicians can make evidence-informed, patient-centered decision and avoid being swayed by marketing claims. So now, let's talk about MOTSI, one of the most exciting mitochondrial peptides identified in recent years. MOTSI is a naturally produced by mitochondria, not the nucleus, which makes it quite unique. It acts as a metabolic regulator, coordinating energy balance at the cellular level, and its main actions are observed in skeletal muscle, liver, adipose tissue, which can improve insulin sensitivity and optimize glucose metabolism. Mechanistically, MOTSI influence pathway like MPK and PGC1 alpha, which are central regulators of energy metabolism and mitochondrial biogenesis. And by enhancing mitochondrial function, it helps cells respond better to metabolic stress, improves energy insufficiency, and may reduce the accumulation of age-related cellular damage. And early studies in animals have also shown promising effects on metabolic health, exercise capacity, and even lifespan, though human data is still a little bit limited. Importantly, MOTSI doesn't act as a hormone in the classical system. It's more of a mitochondrial signal modulator, fine-tuning cellular responses rather than just forcing a systemic effect. And clinically, this makes MOTSI particularly interesting for patients with a metabolic syndrome, insulin resistance, obesity, or age-related metabolic declines. However, as always, we need to temper expectations. So human clinical trials ongoing, effects are subtle and context dependent. So generally, in summary, MOTS represents a very precision peptides acting on specific cellular pathways, supporting metabolism and potentially contributing to longevity, but again, not a miracle cure. And clinically, MOTSI is especially valuable for patients, again, with a metabolic dysfunction, age-related decline, reduced exercise capacity, for our professional athletes when they retired, for professional athletes who recovered after injury. And one of its unique features is its ability to support muscle mass and even promote muscle growth without the need for intense physical activity. And this makes it particularly useful for patients in recovery after injury or surgery, older adults with sarcopenia, individuals aiming to maintain or improve lean mass during periods of reduced activity. MOTS also support glucose regulation, fatty acid utilization, and overall mitochondrial efficiency, which can improve exercise performance once patients are able to engage in physical activity. And administration is typically subcutaneous. We usually use MOTS in 2 directions. We started with a loading dose when we use a 5 mg 3 times per week for at least 4 to 6 weeks. And then we follow by maintenance phase when we use a MOTS 5 mg once per week for another 4 to 6 weeks. And safety profile is absolutely excellent. MOTS is generally well tolerated with a minimal adverse effects responded. And as with all peptides, MOTS is sensitive to temperature, light, and agitation, so correct handling and storage are essential. And by selecting patients with a metabolic or musculoskeletal changes and integrating MOTSI into a holistic care plan, nutrition, recovery, hormonal balance, clinicians can achieve meaningful improvements in energy metabolism, functional capacity, and muscle maintenance. So now let's talk about a topic that is absolutely critical for patient safety: contraindication and side effects of MOTS. First and foremost, MOTS is not available everywhere. It's available in Dubai, Europe, Thailand in compound pharmacy, Japan and China as well, Korea, but not everywhere. So choose your provider carefully. It has not been approved by regulatory bodies like FDA, but we have a published research for MOTS as well. So if we're talking about the contraindication, pregnancy and breastfeeding, because there is no control safety data, competitive athletes, because MOSI is listed as a metabolic modulator on the WADA prohibited list. Severe metabolic instability, such as a poorly controlled diabetes or glycemic lability, because MOTS enhances insulin sensitivity in susceptible individuals, this can lead to hypoglycemia if not carefully monitored. Active cancer or high risk of malignancy, because some preclinical discussion raised cautious about peptides that alter fundamental metabolic pathways, including AMPK and mTOR regulation, which are basically can stimulate the proliferation. And the implication for cancer biology are very complex, and patient with active malignancy should be approached with a very great cautious. Severe mitochondrial membrane instability or dysregulation, while MOTS is a mitochondria peptide, patient with known mitochondrial membrane disorders may respond unpredictably. And because during this condition, we have impairment in the mitochondrial signaling, and it could exacerbate dysfunction. And now if we will move to possible side effects, again, we have injection site reaction. We have a systemic symptoms like a mild fatigue, nausea, dizziness, headache have been reported, especially during early exposure or when using unregulated products. Heart rate changes and palpitation have been described as well. And because MOSI can significantly improve insulin sensitivity, hypoglycemia is one of the main risk factor. So it's also important to emphasize that we don't know. There are no robust long-term human studies, so we cannot predict effect after years of uncontrolled use of MOTSI. What we usually advise to our patients, limit themselves with one cycle of MOTSI once per year. It will provide a safe approach. And now let me expand our discussion of contraindication and caution, adding two important biochemical contexts that are often overlooked: high homocysteine levels and MTHFR mutation. So what do these have in common? Both are linked in methylation capacity, oxidative stress, endothelial function, and metabolic regulation. And core elements of cellular homeostasis. So elevated homocysteine is a marker of impaired methylation. And MTHFR mutation can also be linked with a B complex deficiency or chronic inflammation. And when we talk about MOTSI, why is this relevant for MOTSI? Despite of MOTSI is a mitochondrial peptides that support metabolic regulation, the mitochondria also sensitive to redox balance and methylation status. So in patient with high homocysteine or MTHFR mutation, there is evidence of increased oxidative stress within mitochondria. So most reactive species of the oxygen will be produced. So more oxidative load, more disrupted of the mitochondrial membrane integrity. And MOTSI in this condition of the mitochondrial dysfunction can compromising energy metabolism. So in such biochemical environment, introducing a peptide that further modulates mitochondrial signaling, especially one that interact with the MPK pathway, would produce unpredictable effects. And this is not a definitive absolute contraindication, but rather a clinical relevant cautious. So usually if the patient has elevated homocysteine or abnormal methylation that reflects systemic metabolic stress and impaired regulatory capacity, we have to support this patient additionally. First, we have to stabilize the level of the homocysteine, support the methylation profile, and only after that start the therapy with the MOTSI. So this patient may not respond as expected to the MOTSI therapy directly, and would experience exacerbation of oxidative imbalance, and endothelial dysfunction. So from a clinical perspective, before you will start MOTS, always check homocysteine levels. Again, especially for the patient with a metabolic syndrome, with cardiovascular risk, or history of thrombophilia. And consider testing for MTHFR polymorphism when homocysteine is elevated despite nutritional intervention, and support methylation pathways with a targeted nutrition, like B6, B9, B12, before or alongside peptide therapy, if clinically it's appropriate. And now Dr. Lica, will take it from here. Dr. Lica, it's your turn now.
I'm sorry. I hope you hear me. Yes. As you understood after Dr. Alla's explanation that peptides really are the future of medicine, but you already also understood that they are powerful, they are very different, and we need to understand them really deeper because, as you understand, we can have also side effects, and that's why the peptides have to be prescribed only by doctors. Of course, in this short webinar, we cannot cover everything, full mechanisms, clinical algorithms, and dosing strategies, real patient cases. And that's why we created something structured for you. We created a peptides therapy module, an educational program by doctors for doctors. And this is not just theory, it's a very clinical, practical, and evidence-based medicine. And in our peptides module, we discuss about peptides for weight loss, like semaglutide, tirzepatide, or like Wegovy, Ozempic, retatrutide. We talk about hormonal peptides. We talk about regenerative peptides, neuropeptides, of course, longevity peptides, and we explain everything from the mechanism of action to the protocols, clinical cases, and of course practical protocols. And what is absolutely important, that our course is CPD certified from UK. So after you finish our course, you get 7.5 CPD points. And that's why this is designed for licensed medical professionals. And then you can really use these points to upgrade your license. And also we prepared some bonus for you, for those who participate in the webinar, our 15% discount for the full module and for the single lecture. Yes, because you can buy, for example, a full module, but also you can take one single lecture. Maybe you are interested only in weight loss peptides or regenerative peptides, so you can take only one of it. But CPD points you can get only if you finish full module. And this is not all. Peptides module is only a part of our full program about longevity medicine, functional medicine, and regenerative medicine, which is called Longevity Code. It is 12 module programs that gives you the knowledges on deep theoretical foundation of longevity, evidence-based protocols, and also real clinical case integration. So here it was a question regarding how we can measure the mitochondrial dysfunction before peptides therapy. So here, this you can learn in our metabolic module about metabolic health and mitochondrial dysfunction. And so here we will discuss all future preventive approaches, regenerative technologies, and evidence-based protocols. And here you can see the structure. We have a peptide therapy module, metabolic metabolic health and mitochondrial function. Here we discuss about it. Hormonal therapy, gut health, longevity and functional medicine, IV and nutritional therapy, also ozone therapy, mental health, nutrition, inflammaging, autoimmune processes, biohacking, age-bot, and also sports medicine. So really everything that you need to know if you want to practice the medicine of the future. And now I pass the word to Dr. Alla.
So now we will continue our lecture today, and we will continue with peptide that most of us use personally by ourselves. It's a BPC 157, one of the most well-known peptides and one of the most widely discussed regenerative peptides in clinical practice. So BPC 157 stands for body protection compound, a fragment of a naturally occurring protein found in gastric juice. And unlike classical hormones, it doesn't act on a single receptor system, but appears to influence multiple pathways involved in tissue healing, angiogenesis, and inflammation resolution. Mechanically, BPC 157 upregulates vascular endothelial growth factor and nitric oxide signaling, key players in angiogenesis and vascular repair. That's why it can be useful for our patient with vascular disorders, including erectile dysfunction. It also interacts with the focal adhesion kinase and other intracellular signaling networks that regulate cell migration, extracellular matrix remodeling, and tissue regeneration. And clinically, this makes BPC 157 particularly interesting in contexts like soft tissue injury, tendinopathies, ligament and muscle recovery, and sometimes even gastrointestinal mucosal healing. And there are also reports of effects on the gut-brain axis, suggesting potential benefits for inflammatory and stress-related conditions. Again, overall, BPC 157 represents a peptide that supports endogenous repair mechanism, not a direct growth stimulation. It modulates and fine-tunes biological responses rather than forcing regeneration in a vacuum. And now let's look at BPC 157 in clinical practice. This peptide is widely used and available from compound found in two main forms: oral, like a capsules that you can even mix with a KPV, and injectable. And clinically, BPC 157 is particularly effective for soft tissue, tendon, ligament healing. It accelerates recovery after injury, supports structural repair, making it highly relevant in sport medicine and post-trauma recovery. It also plays a well-documented role in gastrointestinal tract repair. So BPC 157 protects the gut mucus and promotes healing after surgical injury, ulcers, inflammatory condition, is basically able to repair the epithelial barrier in the gut, fighting with the leaky gut. In osteoporosis, it promotes calcium deposition in bones, supporting bone strength and aiding recovery from fracture. For hypertension and erectile dysfunction, BPC 157 enhances nitric oxide production, which improves vascular tone, endothelial function, and systemic blood flow. And administration is typically injectable or oral, although topical application near injury sites is also used. And like other peptides, BPC 157 again is sensitive to light, heat, and agitation, so proper handling and storage are essential to maintain efficacy. Again, in summary, BPC 157 is a multi-target regenerative peptide with a broad application in musculoskeletal, gastrointestinal, vascular, and bone health. Now, let's cover contraindication and side effects consideration for BPC. So although many practitioners use BPC 157 safely, we must keep several precautions in mind. First is, of course, pregnancy and breastfeeding, because the safety data in these groups are quite limited. Known hypersensitivity or allergic reactions to peptides, active malignancy or tumor growth risk, because BPC 157 promotes angiogenesis and blood vessel formation. Autoimmune or inflammatory instability, because in patients whose immune system are dysregulated, modulating repair and vascular pathways could have unpredictable effects, especially in disease with uncontrolled inflammation. Hypotension, vascular tone concern, because BPC 157 enhances nitric oxide signaling, which is a part of its vascular benefits, but this can also lower blood pressure in sensitive individuals. So caution is warranted in patients with a baseline low blood pressure or vascular instability. And side effects from BPC to be uncommon and very mild is usually injection site reaction. From systemic symptoms, it can be dizziness, mild nausea, headache, sometimes fatigue. From gastrointestinal symptoms, cramping or bloating. Theoretical risk, because angiogenesis support both repair and blood vessel formation. There is some concern about tumors. And of course, hypotensive episodes because of nitric oxide production. So the bottom line here, BPC 157 is not free of adverse effect or contraindication, but with careful patient selection, pre-therapy assessment and monitoring, it can be used safely. But again, awareness of this risk is essential for responsible clinical practice. We usually use a BPC in the dosage of 500 mcg once per day in the patient with a severe inflammatory bowel syndrome, ulcerative colitis, Crohn. We can go up to twice per day. And yes, we can use a subcutaneous injection locally for the patient with the injury to help them to recover. Another peptide that will be interesting within our lecture today is a CGC ipamorelin. It's commonly used to stimulate the growth hormone in a physiological pulsatile manner. So it will not substitute the anabolic steroid for bodybuilders. Don't suspect that results, but it will help to maintain the muscle mass, fighting with sarcopenia, and support our patient who is on Manjaro or other incretins to prevent the muscle loss. So in musculoskeletal medicine, it can help to preserve lean mass during aging or post-injury recovery. In metabolic health, it assists in fat metabolism and can support weight management when combined with a lifestyle intervention. In anti-aging programs, it may improve vitality, sleep quality, and overall energy, as these effects are downstream of enhanced growth hormone release. And again, administration of CGC ipamorelin is subcutaneous, usually once per day before sleep in the evening, 5 times per week for around 2 months. And then we need a gap to preserve the sensitivity of receptors for these peptides. Like again, any other peptides, it's sensitive to temperature, light, and agitation, so proper handling and storage is very carefully. And now let's review the contraindication and side effects for CGC ipamorelin that can be happened in our patient. First of all, we will never use CGC ipamorelin during the pregnancy or breastfeeding. We will never use CGC ipamorelin during active malignancy because it can stimulate the tumor growth. Patient with a severe insulin resistance and uncontrolled diabetes should be monitored very carefully, as growth hormone can transiently raise blood glucose. Allergic reaction also can be there. And from side effects, what we usually see is an injection site reaction like mild redness or itching, water retention or mild edema, and headache or mild nausea, tingling or numbness, a rare increase in blood sugar, and it also sometimes can stimulate the water retention in some patients. So with a proper patient selection, monitoring, and dosing, CGC ipamorelin is generally well tolerated and offers a clinically meaningful way to support the growth hormone-dependent regenerative, metabolic, and anti-aging effects. Again, we usually use the CGC ipamorelin in the concentration of 100 mcg of CGC and 200 mcg for ipamorelin. And now let's move to retatrutide. This is one of the most talked about peptides in metabolic medicine today. And retatrutide is a triple receptors agonist, meaning it stimulates and simultaneously engage 3 key pathways involved in metabolism. Glucagon-like peptides receptor, glucose-dependent insulinotropic polypeptides, this is a GAP, and glucagon receptors. And this multi-receptors approach gives retatrutide a broader metabolic impact than all the incretins therapy. So GLP-1 activates suppression of appetites, enhance insulin response, and slow gastric emptying. GIP activation boosts insulin secretion in response to meals and may improve energy partition and fat handling. And glucagon receptor stimulation increases energy expenditure and lipid oxidation, promoting fat loss and helping bring down the stored fat. So together, this mechanism help regulate hunger, improves glucose metabolism, and enhance metabolic rate, a combination that makes retatrutide highly effective for weight loss and metabolic improvement in clinical trials. Importantly, retatrutide, despite being widely talked about and even used informally in some circles, remains an investigational compound. So meaning it has not yet completed regulatory approval and is not licensed for general clinical use. Retatrutide has demonstrated impressive weight loss and metabolic improvement in rigorous phase 2 and ongoing phase 3 trials. For example, in 48-week phase 2 study, participants treated with a weekly retatrutide activated mean body weight reduction up to 24%, significantly greater than previous seen with the GLP-1 and dual incretins agonists. It administered once weekly by subcutaneous injection with a long half that support this regimen because it remains under clinical evaluation. Retatrutide cannot be prescribed outside of the approved trials. But why we review these peptides here? Because we have a lot of patients who is currently on retatrutide, and we have as a physician to guide them safely. So if we're talking about the dosage of retatrutide, we usually started with the smallest, tiniest dose. It's a 1 mg once per week. We don't suspect the significant weight loss from this dose, but it will help us to prevent the complications and side effects and to help the body to adapt. And then we gradually increase the dose going through the 2 mg once per week for 3 weeks and then 4 mg once per week again for 4 weeks, and we can go up to 12 mg, but generally we don't recommend so high dose in our patient if the medication is not effective at the dosage of 4 to 8 mg. It makes sense rather to substitute it for something else or to add additional one from the another group and to help our patient to reach their goals without the increasing and reaching the highest dose, because sometimes the problem will not be with the retatrutide, but with the lifestyle or with the underlying thyroid issue or mitochondria dysfunction. So retatrutide is particularly exciting because it combines 3 metabolic pathways, GLP-1, GIP, and glucagon receptors activation, producing broader effects than previous incretin therapies. And one of its key advantages is that it's preserve lean muscle mass during weight loss, something all the GLP-1 monotherapies could not fully achieve. And this is crucial for long-term metabolic health, functional capacity, and preventing sarcopenia. And compared to GLP-1 monotherapy or dual agonists like a tirzepatide, retatrutide demonstrates greater weight loss, improved glycemic control, and additional benefits for cardiometabolic health, liver fat reduction, and inflammatory markers. Its combination of appetite suppression, insulin sensitivity improvement, and energy expenditure enhancements is what makes it highly anticipated by clinicians and patients alike. Again, to understand retatrutide in context, it helps to look at the evolution of incretin peptides. The first generation, it was a GLP-1 monotherapy. It was primarily acted on appetites, helping patients feel full and reduce calories intake. And this was the mechanism behind early semaglutide studies. The second generation dual agonists like a tirzepatide added effects on insulin receptor sensitivity, improving glucose uptake and metabolic control in addition to appetite suppression. And the third generation, including retatrutide, introduced energy expenditure and enhanced fat oxidation via glucagon receptors activation. So this generation not only regulates appetite and insulin preservation of lean muscle mass, it's a key differentiator. So each evolution step reflects more comprehensive engagement of metabolism, translating into progressively greater clinical benefits, and retatrutide represents the current pinnacle of this development. Although retatrutide has been well tolerated in trials so far, it shares many contraindication and safety consideration with other incretin-based agonists due to its mechanism of action. So general cautions include, of course, pregnancy, breastfeeding, again, where safety data are insufficient, because incretins agonists may affect endocrine pathway in individuals with a personalized or family history of medullary thyroid carcinoma or multiple endocrine neoplasia type 2 are typically excluded from the trials and should be approached with a caution. Severe gastrointestinal diseases or active pancreatitis are also relative contraindication given the GI effects these therapies can induce. And common side effects observed in clinical settings tend to be gastrointestinal, I mean nausea, vomiting, diarrhea, constipation, reflecting slower gastric emptying and central appetite effects. Injection site reaction can also occur. Dose-dependent effects on appetite and glucose metabolism are expected as part of the pharmacological activity, and these require, again, careful monitoring in practice. So it's very crucial to emphasize that unregulated use outside of legitimate clinical trials or approved context possess safety and legal concerns. So particularly given the variability in product quality and dosing, this is what we also have to consider. And when we talk about who is suitable for peptides therapy, it's crucial to remember that it is not about marketing driving promises or chasing symptoms alone. The ideal candidate is someone selected based on objective biomarkers, for example, growth hormone deficiency, impaired mitochondrial function, tissue repair needs, or metabolic dysregulation. And lab data imaging and validated functional assessment should guide therapy. So peptides are tools for metabolic optimization, regenerative support, or anti-aging strategy, not one-size-fits-all reminders. And by focusing on the biomarkers driven intervention, we reduce risk and maximize clinical benefits while avoiding high-base prescribing that often misleads patient. And ethics in peptide therapy is paramount. Always obtain informed consent, clearly explain what the therapy does, what is unknown and potential risk. And again, most peptides we discuss, especially newer or investigational ones like retatrutide, are used off-label. So patient must understand that clinical evidence may be limited or ongoing, and transparency protects both the patient and the clinicians. And finally, managing expectation is critical. So peptides can support regeneration, metabolism, and anti-aging process, but they are not miracle solutions. So framing therapy realistically helps patients remain compliant, satisfied, and of course, safe. And peptides work best as part of a comprehensive system. They are not standalone magic bullets. So nutrition, sleep, exercise, hormonal balance, all of them, they build the proper base and make environments suitable for peptides use. We never ever use a peptides like a standalone solution. We always implement them in our protocol that will affect all aspects of the patient health. And to wrap up, remember these key takeaway. Peptides are powerful tools, but they don't replace lifestyle, medical management, or comprehensive care. They adjuncts, not miracle solutions. And clinical decision must always be guided by evidence, not trends, social media hype, or patient demand alone. Again, understanding mechanism of action or targeted tissue, dosing, and safety is essential. And finally, the future of peptide therapy is intertwined with the mitochondrial health, energy metabolism, and tissue resilience. Focusing on these fundamental processes allow us to use peptides effectively and responsibly. And as we close, remember, peptides occupy a unique place in medicine. They are grounded in real biochemistry, and yet they are also surrounded by marketing and exaggeration and hype. Our responsibility as clinicians is to discern evidence from illusion, integrate peptides safely into holistic care, and communicate transparently with the patient. And when we use peptides thoughtfully, guided by science, biomarkers, and system-level understanding, they can support regeneration, metabolic health, and longevity. Misused, they can mislead patients and risk safety. And ultimately, knowing the difference is the clinician's power and responsibility. And this is the heart of the practicing peptides therapy with integrity. Thank you so much for being with us today. Thank you for your attention, and see you later.
Thank you, dear Dr. Alla. Yes, I will also share my screen now. And thank you, dear doctors, for all of you for being with us. And because we had the doctors from all over the world, Sweden, Germany, Cyprus, UAE, Lithuania, Romania, Northern Ireland, Canada, Ukraine, Algeria, UK, Finland, and many other countries. So thank you for being with us. And please, for those who maybe wasn't with us, I will just repeat, and you can scan the QR code. So it is available full peptides module where we discuss everything with the protocols, with the clinical cases, indications, contraindications, also the investigations that we need to do before starting the peptides therapy, and how we can combine with other supplements or other therapies in our longevity clinics, where we talk about weight loss peptides, hormonal peptides, regenerative peptides, neuropeptides, or longevity peptides. You can take a separate lecture, or you can take a full module. And our module is CPD certified from UK, so you will get 7.5 CPD points after completion and finishing a short test. And you will be able to use it for updating your medical license. So here you can also check and scan the code to see all the information about the course. And we also created a bonus for you, for those who participated at the webinar, 15% discount for the full module or for the single lecture. But the CPD points you can receive only if you take the full course. But if you're interested in a full longevity code program, where we learn about functional medicine, longevity medicine, regenerative medicine, then we welcome you to our longevity code course with the deep theoretical foundation, evidence-based protocols, and real clinical case integration. So for all the doctors who participate with our course, we have a closed Telegram channel where you can always ask the questions regarding your patients, and so we will also consult you during your longevity journey with your patients. And also you will have the clinical protocols available that you can use and download them. And here you can also scan the QR code if you want to learn about all the modules that we have. So peptide therapy, metabolic health and mitochondrial dysfunction, hormonal therapy, gut health, longevity medicine, IV and nutritional therapy, also zone therapy, mental health, nutrition, inflammaging, biohacking, and also sports medicine. So really everything that you need to know if you want to practice longevity medicine. And also please join our Telegram community, so where you can also see all news regarding longevity medicine, our Telegram channel, our Instagram page, Lica.Doctor Academy, and also my page and Dr. Alla's page. We had a few questions during the, and thank you for your participation and for your activity. And here it was about the If the laboratory has to have a certification, of course, if we use peptides or that are from compound that we take from compounding pharmacy, which have GMP certification, and all the certificates we work only with this kind of peptides, and they are available in the UAE and in Europe and in USA, in Thailand, as Dr. Alla told you, and. Also, regarding the prices, already we can talk in our closed Telegram channel when you take the course. Also, yes, you will also receive the email with all the information and regarding the course. And here it was a question regarding the dose of BPC. Maybe, yes, Dr. Alla, you will reply. Yes, about the dose of BPC.
So generally we use a BPC at a concentration of 500 mcg. We use it once or twice per day, depending on the patient condition. If we're talking about a while and you need to reconstitute it, we usually use it concentration 2000 mcg in 1 ml. And then the patient has to inject 0.15 ml. This is a 15 international units in the insulin syringe. But generally it's a 500 mcg.
Yes, thank you, Dr. Alla. And yes, dear doctors, you can always ask us in our closed Telegram channel. You can also ask us in our Instagram account, Lica.Doctor. Thank you for being with us, and see you soon at our next webinars.